Good afternoon, everyone, and welcome to the Atlanta Press Club. My name is Christy Wooten. I'm president of the club. Thank you for joining us today for our Newsmaker event, The Pandemic and the Epidemic, How COVID-19 Impacts the Fight Against AIDS. We have an incredible panel with us today, and I'll introduce you to them in just a few minutes. But first, I want to thank you for your support of the Atlanta Press Club. As we all know, quality journalism is more important now than ever before. We are winding up 2020, and we are grateful that you have stuck with us through all of our virtual events this year during the COVID-19 pandemic. We are also grateful for today's program partner, the National Center for Civil and Human Rights, based here in Atlanta. The Center's Campaign for Equal Dignity provides community resources and education and amplifies the work of advocates working to protect rights and dismantle structural racism. Thank you to the National Center for Civil and Human Rights for being our partner today. So we have a little reminder today also. I want you to be able to tune in to the Atlanta Press Club Loudermilk Young Debate Series. It's happening this Sunday, December 6th, beginning at 5 p.m. You can watch it live on GPB TV or gpb.org or the Atlanta Press Club's Facebook page. I believe other media outlets, both regional and national, will be carrying it. And this is where you can see the U.S. Senate candidates Jon Ossoff and Reverend Raphael Warnock, as well as incumbent U.S. Senator Kelly Loeffler. They will participate in these debates, which will be moderated by WAGA-TV Fox 5 anchor Russ Spencer, with Atlanta Journal-Constitution political writer Greg Bluestein and Lisa Rayam from WABE Morning Edition host and senior producer as panelists. Today's agenda, we have obviously a World AIDS Day event, a great discussion ahead. Our local panel will discuss Georgia's current HIV stats, the impact of the coronavirus pandemic, what community organizations and advocates are doing to improve the outlook for 2021. And our global panel will discuss the global COVID-19 response, how HIV prevention and treatment must be a part of the recovery plan for 2021, and the importance of advocacy and consistent funding in the fight against AIDS. After these two panel discussions, we will come together for an audience question and answer session. So please enter your questions either in the chat or the Q&A function at the bottom of your Zoom screen. Now I'd like to introduce our guests today. You can see their bios in the chat. We've put each one of them in there as a little note in the chat so you can read about them. But we have our moderator, Gracie Bond-Staples today, longtime Atlanta Journal-Constitution lifestyle reporter and columnist. She has written award-winning stories about the HIV/AIDS epidemic and its impact on Georgia. She won the 2018 GLAAD Award for Outstanding Newspaper Article for her story, The Silent Epidemic, Black Gay Men and HIV. It was a look at how HIV affects the gay community, especially in the South. She joined the AJC in July 2000, so we're happy to have Gracie here with us today. Also joining us today for the local perspective panel is Charles Stevens of the Counter Narrative Project, Antoinette Jones from Sister Love, and Ryan Lee, who is a reporter and contributor to the Georgia Voice. For our global perspective panel, we have Dr. Hank Tomlinson from the CDC. We have Sarah Maka Ugbabe, the Nigeria director for the One Campaign, and John Hassel, who is National Director of Advocacy at the AIDS Healthcare Foundation. So we'll get right into our local perspective discussion. And I wanted to just share some information that our audience may not know. Atlanta has a long history as being a global center for AIDS research and advocacy. The CDC first used the term AIDS in 1982. Atlanta was also the home of the first International AIDS Conference held here in 1985 and presented by the CDC, the World Health Organization, and Emory University. Atlanta held its first AIDS Walk in 1990. And in the years thereafter, I know many of you probably remember seeing pictures of Elton John participating in those events and engaging celebrity activists in the cause. And Atlanta, of course, has a long history of activism in the LGBTQI community. And we'll discuss all that and more. And I'll let Gracie take it away with our questions right now, and then we'll be back with the global panel.
Good afternoon. Thank you, Christy, for the introduction, and welcome everyone to the World AIDS Day conversation. I've been tasked with moving this discussion along, so let's get started. I want to direct my first question to Ryan. Ryan, what do the stats say about Georgia's ongoing efforts to reduce HIV infections?
It remains a struggle. Georgia continues to be in the top 10, sometimes top 5 of both HIV transmissions and just the prevalence of HIV. In Atlanta Metro, about 40,000 people are living with HIV, and I think that ranks us around 3rd. I can't say that for sure, but definitely in the top 10 of cities, and that's been a historic problem. Culturally, I think Atlanta is shorthand for the HIV epidemic. I think, when people say, oh, Atlanta, there's connotations there. And so it's a reputation that we carry. And so it's been a persistent struggle that you're not winning on many levels. But I will note that there were only 350 deaths from HIV and AIDS related complications in the latest figures. And so it's incredibly expensive to keep those HIV transmissions from becoming AIDS deaths. But there's also room for us to work with that narrative to reduce some of that stigma and to reduce the image of Atlanta as sort of the walking dead when it comes to HIV. And there are groups here in Atlanta that are trying to change that narrative and give a more empowered outlook.
Mm-hmm. That's interesting because Atlanta has been, I've even done stories about from people who say that unless you solve the HIV/AIDS epidemic in Atlanta, you don't solve it anywhere. Do you happen to agree with that?
Absolutely. I think Atlanta would be a prime case study for what could work and what doesn't work. We have factors that drive HIV in terms of poverty, a vibrant gay population, systemic economic inequality that drives some of these things. And so absolutely, I think if we can learn things in Atlanta, then perhaps they could be extrapolated to other areas.
Yeah, and so now we're having this twin epidemic of COVID-19, and so Antoinette, I wondered what you thought about that and what personal changes, precautions are the HIV positive community taking during the COVID-19 pandemic. I think you're on mute.
Can you hear me now?
Yeah, now, yes.
Awesome, thank you. So when the COVID pandemic first came on the scene, there was a lot of fear for advocates and peer specialists like myself who are living with HIV, because we worry what COVID could have possibly done to us if we living with HIV and then we contracted COVID, especially with seeing the numbers in the world and the number of deaths. It was a very scary time, but once research started to develop around COVID and people living with HIV, we see that those who are undetectable have a less likely chance of contracting COVID. So what I started, at least in my community, I started a peer check, which is like checking on your community of peers living with HIV, just making sure that they're staying on their medicine and that you're supporting them in any way that you could. And that just a little thing that could decrease the chances of contracting COVID. So just bringing awareness to that and education.
Yeah, I'm happy to hear about the work that you've been doing, but do you feel at liberty to kind of share with us some of the changes you yourself have taken to protect yourself?
Definitely. Being born with HIV, I've always experienced burnout from just living with HIV and taking medicine and going to doctors. But I wanted to be extra cautious during this time. So I made sure to get my medicine at least 3 months in advance, made sure to schedule my doctor's appointments virtually, and just stay in touch with my provider, asking as many questions as possible, just taking an extra step to take care of myself and not be so relaxed about my care and being more strict with my HIV care. And in addition to other things that I do, so working out or eating healthier, to just doing things that build my
Okay, thank you so much. Charles, how about an overview of where Atlanta is right now in terms of being able to meet the needs of its current HIV positive population, as well as any prevention measures?
Absolutely. But first, I would like to make sure that I publicly thank Jewel Wicker, who received this email about this idea for this program. And she's just been not only a brilliant journalist, but just an amazing voice and leader. And I'm just so grateful for Jewel Wicker and just helping move this forward. And I don't believe that this would have happened without her, this conversation we're having. But to answer your question directly, I want to say that when I think about the unique position that Atlanta rests in, I think about the challenges and struggles that Atlanta has experienced with regard to providing services for folks living with HIV and resources. But I also think about the movement landscape. I think there's an incredible history of activism in Atlanta, and what makes Atlanta's HIV movement landscape, I think, very unique is a lot like the civil rights history that we take inspiration from, and that is absolutely framing HIV as a racial justice issue. Very often, unfortunately, many narratives around HIV center only on how individuals are impacted, and certainly that's important to consider, but one must also look at such things as institutional failures. One must look at such things as failures in ensuring that marginalized people have access to healthcare. So when I think about HIV, I really do think about HIV as a racial and economic justice issue. And there are many activists that have been able to move the needle and make and really create advances in treatment advocacy, treatment and prevention for folks living with HIV and people impacted by HIV through their advocacy work. So I think that's just a really important point to mention. I think Atlanta has been on the vanguard. I mean, again, there are many things wrong and we have a long way to go, but I also think one of the things that we've gotten right is making sure that we talk about HIV as a racial justice issue and look at just the intersectional nature of HIV. The second thing I want to bring up in relation to the question is just the important role that journalists play in combating HIV stigma. I think there are many great examples of partnerships between journalists and community leaders to be able to tell a story about the HIV landscape in Atlanta that doesn't reproduce HIV stigma, that doesn't reproduce discrimination. As I think we all recognize, narratives are very important. Public narratives are important. The role of journalists is also important. And far too often, public narratives can be weaponized against vulnerable people. So we have to make sure that in our efforts to get the story right and put out information, that the information is accurate, that it doesn't reproduce stigma, and that we are talking about people impacted. And I think there are many journalists that have, even local journalists that I'm really inspired by, including folks on this panel like yourself, Gracie and Ryan. And I also just want to just point to Tamar Hallerman, who covered the efforts to address the HIV criminalization law in Georgia in the AJC. She wrote some great coverage talking about activists, and also Thomas Wheatley, who wrote did some great journalism many years ago for Creative Loafing around HIV.
Okay. You mentioned institutional failures. Can you be more specific about what you're talking about there?
Absolutely. You know, I think that to talk about HIV isn't just to talk about individual behaviors, i.e. someone did something. We also have to talk about the role of healthcare providers. We have to talk about the role of clinics and clinicians. We have to talk about the importance of cultural competence in healthcare settings so that there aren't barriers to healthcare. Everyone that that seeks healthcare should have access to healthcare. But what we found, and we see this particularly with folks seeking HIV prevention and treatment resources, is that there are barriers from lack of cultural competence of healthcare providers, economic barriers, barriers around transportation. And so it's not enough just to provide healthcare resources. We also have to work to reduce and eliminate barriers so that when people are seeking treatment and prevention as it relates to HIV, that they're able to get the resources they're seeking.
Yeah, that's a good place to segue into this next question I want to put to Antoinette. How has the COVID-19 pandemic affected access to healthcare and treatment?
Well, what we see is a lot of places closing down or not being able to offer the full amount of services that they offered in the past. So I know for me, like I mentioned, just my provider shutting things down immediately and just only doing telehealth or only seeing us if we felt like it was a need. And also just working at Sister Love, we had to close our doors temporarily as we figured out how this COVID pandemic could possibly affect not just us as staff, but our clients as well.
Mm-hmm.
And we wanted to protect everyone. So we did have to move to a more mobile or virtual way of doing things as far as our HIV test, as far as our COVID testing, and doing everything that we can to remain.
Thank you. Antoinette, were you done? Or did you just go mute? Okay, all right. All right, so I want to move to Ryan, back to you. How has the local media responded to the COVID-19 pandemic in terms of covering HIV, AIDS, and vulnerable, underserved populations?
Given the saturation of COVID coverage, it doesn't seem to have been too included. It seems like they've written a story about COVID and everything, but there hasn't been too much focus on that. It could be because HIV, while it is a pre-existing condition, doesn't seem to be one of those particularly worrisome underlying conditions that COVID's been taken advantage of. But it's, I mean, media in general have overlooked many of the HIV and AIDS developments over the past 30 years, and which is why so much of the popular understanding of AIDS and HIV is Magic Johnson. You know, people still consider him to be the exception and all these kinds of things. And that's based on the media narrative or the lack of media involvement over the years.
Mm-hmm. Has that made your job harder, the COVID at all? Covering the community?
It is not the type of writing that I do. You know, there are less events to cover and less pools people to tap into in terms of common spaces, but not.
Yeah. Okay. All right. I'm always surprised by the number of emails I get from people during certain times of the year when they even take the time to pitch stories about HIV/AIDS. It's like, you know, it only happens once or twice a year when people get with HIV/AIDS. It's very interesting when it's a story that's ongoing, and we should be covering that story just that way. Charles, still there? Yeah. Okay. Has the COVID pandemic exposed the vulnerable, underserved populations already in the HIV/AIDS community?
Oh, absolutely. I think the COVID pandemic has exposed how many communities are experience structural violence and experience discrimination. I think that perhaps as we look back at 2020, of course, we'll certainly be forced to reckon with COVID-19 and how it's impacted us. But part of the history of 2020 is also the history of combating anti-Black racism and police violence. So I think about 2020 as being an interesting year where you have this intersection of both the pandemic, but also a resistance to anti-Black racism, particularly as it relates to law enforcement. And I think where those converge is absolutely happens in the HIV justice movement space and the HIV community, where you also have folks that have been fighting and combating laws that punish people living with HIV, the HIV criminalization laws, in which Georgia also has the HIV criminalization law in the books. And so I think the opportunity that we in the movement and activism space see ourselves in is absolutely seeking to continue to resist, to continue to fight back. And I think that, you know, certainly there are many people in the COVID-19 space that can look to HIV activism, the history of HIV activism, and the present of HIV activism in terms of how to, for blueprints as it relates to community organizing and advocacy efforts.
Okay. Well, I actually received an email today from the Center for Health and Gender Equity, and they're calling on the incoming Biden administration to make a $1 billion investment in the DREAMS program. Anybody want to react to that? Charles, Antoinette, either one of you?
Could you say a little bit more? I didn't receive I wasn't a person that received the email, so I want to make sure that if I comment, I have good context.
Oh, I don't have a lot of information about it either, but I just got a brief email saying the Center for Health and Gender Equity is calling on the incoming Biden administration to make a $1 billion investment in HIV/AIDS programs.
I can comment on that, Gracie, if you'd like.
Okay.
I know I'm stepping out of my panel, so I want to.
Okay, as long as you know what I'm talking about.
The Dreams Initiative is dedicated to young women and girls.
Okay.
And in parts of sub-Saharan Africa, 75% of the new infections are in that population. 75%. That's a lot of the new infections are found to be in that population. So that is a very targeted effort to look at how can we reach young women and girls, keeping schools open, for example, during COVID, because if girls are left at home by themselves, they're much more vulnerable towards, intergenerational sexual relationships that put them at risk for acquiring HIV. So it's really targeted at that, empowering women, empowering girls, teaching them to stay in school, to be career oriented, but also basic things like feminine napkins. Because if a girl is on her period, she's less likely to go to school if she doesn't have, that kind of help. So it's I'm really skipping over the important details, but it is an initiative within the President's Emergency Plan for AIDS Relief, PEPFAR. And Ambassador Birx was heavily involved in establishing it, and it's good to see that President-elect Biden is building on that.
Yeah.
See, I can chime in with this answer as well. So DREAMS, as John just mentioned, is a program that was started about 6 years ago by the President's Emergency Plan for AIDS Relief and other private sector partners. So it's a public-private partnership, and we've had about $1 billion of investment over the last 5 years alone. And it's an effort that layers different kinds of interventions on top of one another to try and reduce risk for HIV acquisition among young women and adolescent girls in sub-Saharan Africa. And so there is a suite of interventions that are part of the program. DREAM stands for Determined, Resilient, Empowered, AIDS-Free, Mentored, and Safe. And the interventions that are included in the core package include school-based interventions, parenting and caregiver programs, social protection, to improve education and socioeconomic outcomes, social asset building, youth-friendly sexual and reproductive health care, and work that will happen to sort of prepare adolescent girls and young women to sort of engage sexual partners responsibly. So it works with women themselves, it works in the settings that they work to mobilize communities for change. It's focused on sort of empowerment, and what we find is that, or what we hope is that the more of the layers that a country can do, or a government can do, or private partners can do, and the more that you can layer on top of one another, the greater the protective benefit for adolescent girls and young women, and the the greater the reduction in the likelihood for acquisition of HIV over time. And so I think what you heard today was that there had been $1 billion of investment. Folks are really excited about the results that that has produced, and folks are calling for more.
Okay, so should I assume then too that, I mean, you may have answered this question and I missed it somehow, but some of this money, if it comes to fruition, will trickle down to Atlanta, Georgia?
No, so Dreams is a global program, and a lot of it's built on things that have been demonstrated to be efficacious in other settings, including in the global north and the United States. And some of these programs are implemented now by community organizations, other national non-governmental associations, some state and local departments of health and whatnot. So it attempts to replicate what might have been brought together in the United States by disparate actors into an overseas setting where one actor or donor funds it all.
Okay.
And Gracie, can I just chime in here? Because I wanted to, before we leave the Georgia panel focus, just get a question in about talking about young girls in other parts of the world, but also the statistics in Georgia. And I'm sure some of you probably know better than I do, but it seems to be about 35% of the people living with HIV in Georgia are under 40 years old. So, and then I'm sure there's other demographic breakdowns in terms of the ages with that, but could any of our Georgia panelists speak to the trends in Georgia with regard to those age groups and how you're targeting, or how organizations are targeting younger people? I mean, a lot of us who grew up in the 80s and 90s think of AIDS as this thing that started so many years ago that everybody who's HIV positive must be 70 now or something. It's like there's sort of a mentality there, but there really is that population. And Antoinette, I know you can speak to it, but others as well. Just as I'm interested in knowing about that demographic angle, the age.
Yeah, I'd say HIV/AIDS continues to, new cases of HIV/AIDS continues to appear across ages, particularly amongst particular groups like Black gay men in Atlanta. Atlanta's epidemic, I think the largest percentage of new cases is between 25 and 44-year-olds. I think that age group makes up more than half of new cases. And so you're talking about, millennials and some a little older exennials and things like that. So you've got, it's that large group spans people who have heard various messages. On the older end, you have folks who are familiar with HIV as a death sentence and have some memory of that culture back in the early 90s of what HIV meant. And then you have people who were, graduated high school in 2010, and they might not. They know the letters and everything, but they don't understand the scope of it. And so it'd be interesting in how organizations tailor those two messages. I'm not sure Atlanta's or any HIV organizations are using social media influencers. I know they use, ads on some of the dating apps and things like that, but they really haven't seemed to get a foothold in digital or virtual meaningful connection with folks to talk about safer sex and testing and prevention and things like that. And it'd be interesting to see their strategies as things continue to remain digital due to COVID. How do they do, condom distribution, and since they can't go to the nightclubs and things like that.
Mm-hmm.
I think one of the things Atlanta's done well is marketing. You often see billboards, particularly in economically distressed communities, with messages around HIV and sexual health. I think that where we can go further, particularly as we seek to reach younger folks, is around the stories that we tell. And again, I really do hope that, there are more journalists that are willing to tell the stories of young people and reach young people through the storytelling, whether it's partnering with Vox and some of the local organizations that reach young people. I also think there's an opportunity for college presidents in Atlanta. Atlanta's often considered a Black college town, but really, I think it would be amazing if there were like a roundtable of college presidents here in the city that really sought to make information around HIV a priority and really seek to create opportunities for their students to learn. And finally, I want to share that I think that, I mean, again, I think it just comes down to stories. I think that we market endlessly to people, and though there's some value in social marketing, I don't think we have enough opportunities to really educate and really move hearts and minds. And so my hope is that we're not only do we see more stories about how young people are impacted by HIV in Atlanta, but we actually create platforms and pipelines for young people to tell their stories so that they're able to reach their peers more effectively.
Thank you for that.
Christy, I'm going to pivot back to you if we have any, I guess, audience questions.
Yeah, we'll be moving to audience questions in a bit. I'm going to try to share the screen again and see if we can pivot to our global focus here now.
Okay.
Here we go. So thank you for that discussion. We could go on and on and on, and this is very educational for all of us. We have such a wide variety of people on this Zoom, and I'm very grateful to each of you for your perspective, because it really is eye-opening, and I hope our audience is getting as much out of it as I am. But we want to pivot now to sort of the global overview and the global response to COVID-19. I know we talked a little bit about the local response, how the global response to COVID-19 is impacting HIV positive populations, people living with HIV, talking about disruption of care, global HIV trends. And we touched a little bit on, subjects such as PEPFAR, advocacy for funding, those things we definitely want to talk about. A lot of that really is a big deal on the global level. And it's important. And I know there are a lot of cogs in the wheel, but people really trying to turn the machinery to make sure that no matter who's in office, that funding keeps coming forward for that. So Gracie, if you want to take it away with our global panel, that'd be great. Thank you.
Sure. First, I just want to say a quick thank you to Dr. Tomlinson and John for saving me on the dream question. And my first question is to Dr. Tomlinson. I want you to talk about a little bit what we've learned from decades of HIV/AIDS response that has helped with the COVID-19 response.
Sure. Thanks, Gracie. So, as I think we heard earlier, we're almost 4 decades into the domestic HIV response. CDC identified the first cluster of what would later be called HIV and AIDS in Los Angeles in 1981. And we've been working domestically since then. Globally, our effort is a little younger. So PEPFAR, the President's Emergency Plan for AIDS Relief, was begun just about 18 years ago. And there was some work that preceded PEPFAR with the LIFE Initiative and some specific activities at CDC and a couple of other agencies in global settings. But by and large, we're about half as old as the domestic effort. But during that last 17, 18, 20 years that we have worked on HIV significantly in global settings, we've learned a lot. And so some of the things that I think matter and that are relevant are, I've picked 6 things to focus on. The first is that I think person-centered and client-centered services work. We hear a lot and we talk a lot now about human-centered design. And I think it's just a label that we give at this point in time to acknowledge a fundamental truth that if something works for people, they're more likely to do it. And if something doesn't work very easily for people, or there are substantial barriers to engaging in a behavior, it's harder for people to do it. It's less likely that behavior occurs. That's true for HIV prevention, testing, and treatment. And it's true for the set of things that we've seen in the last 10 months in global settings for COVID-19. And so keeping the person or the client at the center of program planning and program implementation and service delivery is one of the things that's been essential in HIV, and that we didn't always do it this way. We've learned over time that to be successful, this is what's required of effective programming, and that's a lesson learned that conveyed into our global work for COVID-19. Secondly, I would say that sort of as a government and a set of actors within the United States government, we've learned a lot in the last several decades about how to work with and engage global partners, particularly with ministries of health in the countries in which we work. So my office at CDC works in about 45 other countries on their HIV responses. And we work very closely, usually hand in glove with ministries of health and other local indigenous partners on the ground. it's critical that that effort to about 70% of our extramural portfolio goes to those indigenous or local partners, and their understanding of context, texture, and nuance on the ground is essential in helping us to sort of identify and close gaps in HIV, and it's equally as critical for COVID-19. Another thing that's really important to my agency that's true for HIV and for COVID-19 is that we have to collect and use data as we go. With COVID-19, you've seen just in the last 10 or 10 and a half months in the United States, how we have gone from identifying a novel pathogen, a novel coronavirus, to not knowing very much about it in the beginning, learning a little bit more, and then now sort of, you know, increasing our knowledge base, which helps us not with just understanding the basic scientific aspects of the virus and its transmission, but also the epidemiological and the sort of treatment related aspects of our work. And so use of data, collection of data, and active utilization of those data as we go, not for a periodic quarterly or semi-annual or annual review, but every week sort of making sense of data and using those data to understand, identify, characterize a problem, and to let that guide our response. That's true for HIV, it's a foundation or bedrock of our practice, and it's true for COVID-19 as well. Next, one of the things that I know, you've already heard about this in the context of criminalization of HIV in the United States, but I would say policies matter. And public health interventions, public health practices, and public health programs succeed or fail to the degree that there are enabling and supportive policies at the national, the subnational, and local levels. And so you can have the best, you know, the most efficacious intervention or practice, and if that is demonstrated in a setting that isn't, you know, if it's demonstrated to be efficacious in a tightly controlled research setting, but it doesn't work out in the real world because the government hasn't established policies that enable or support that thing working, or if they're actively policies that work against its success, you're likely to be met with limited success. And so we've seen during COVID-19 how important policies can change very, very quickly. It's actually been catalytic for some of the things that we've worked on in global settings in HIV for quite some time. And so dolutegravir is a drug that's part of a multi-drug cocktail, a combination therapy in the United States. It's been part of a typical first-line treatment for HIV. That hasn't been the case in the global South and in the 45 countries where my program works and the 50 countries where PEPFAR works. And so we've been working for the last year and a half to move towards dolutegravir-based regimens and to try and create, you know, to try and increase uptake of a 3-drug cocktail that's really inexpensive and has superior efficacy, fewer side effects, better tolerance, you know, by patients, and that will lead to better clinical outcomes. Well, folks in some countries did that quickly. Folks in other countries did that, you know, less quickly, and some governments were reluctant. We saw that somehow during the time of COVID-19, the supply chain issues that might have plagued a government, the challenges that might have shown up in decision-making were able to be confronted and dealt with successfully. So we've seen dolutegravir-based regimens rapidly picked up and policies that enable that to be changed. In most of sub-Saharan Africa, a year or 2 years ago, you would have to go to the clinic and to the pharmacy once a month to see your provider and to pick up a prescription for your medication. We've moved in the last 2 years to have 3-month prescription and dispensation of drugs. And for stable patients in the last, you know, year and a half, tried to get to 6 months of stable, 6 months of drug dispensation for stable patients. There were a lot of policy barriers to that, and a lot of local governments or host country governments were reluctant to make those changes. During the time of COVID-19, where you don't want people going to public facilities, to hospitals or to clinics, because congregate settings can increase the likelihood of acquisition of COVID-19 or of transmission of COVID-19, you wanted to decongest those facilities, keep people at home, make sure they got their drugs. We were able to get to 6 months dispensation in a few dozen countries and to 3-month dispensation in many, many more. It's also accelerated the adoption of differentiated models of service delivery for TB preventive treatment and other things. So policies matter. Then I'll quickly go to the last two. the fifth is super important. So we should purposefully build systems, infrastructure, and capacity in a way that's helpful beyond a narrow scope or beyond a vertical program. And so in HIV in the last 20 years, we've worked assiduously to purposefully build systems for laboratory work, for surveillance, for supply chain and commodity distribution that don't just work for HIV. For human resources, for health as well. All of the things that you build in overseas settings for HIV have been able to be applied to COVID. So learning how to, I mean, we've got more than 1,000 laboratories around the world now that have the capabilities of doing the molecular diagnostics to identify COVID-19, to do a COVID-19 test. That didn't exist 15 years ago. It didn't exist 10 years ago. We've got the ability to perform surveillance activities that can help us identify when and where there are outbreaks, where there are trends, where there are gaps, so that we can target our programs and our activities that in global settings have very limited capacities, target them where they're most needed. And we can use our supply chain activities that others in the US government are more expert in to get commodities and materials to where they're most needed. And finally, I'd say what we've known to be true in HIV for many, many decades has been shown to be true in COVID-19, which is necessity forces innovation. And where there is need and you have enterprising, dedicated people, they can come together to solve problems, no matter how significant those problems seem initially.
Wow, you've done a lot. So, John, I feel a little guilty asking you this question. I don't know why, but you'll know when I read the question, okay?
All right.
Has the media covered the pandemic's effect on the AIDS epidemic?
No, but you probably want me to say more than that. You know, there's been there were early on in the coverage of the COVID epidemic, there was some comparisons, you know, what did we learn from our response to the HIV epidemic? And, you know, there was some coverage about that. So I would say at the beginning, yeah, there was some of that, but the point I want to leave with you, if you forget everything I say, is that we can't let history repeat itself in the situation where we let millions of people die unnecessarily from HIV because of inequitable access to medicine. I recommend to you the documentary film Fire in the Blood, where up until the year 2000, we basically let the drug companies dictate that it was just too expensive to respond to the HIV epidemic. And 75% of people living with HIV are in sub-Saharan Africa. I primarily focused on the domestic response in my current job, but I did work for UNAIDS for a while. And so I'm you know, it is my first love, but we really made that decision to let the drug companies do what they wanted to do in terms of lack of equitable access. And it's not just the drugs, it's all the care that goes with keeping people, you know, in care, in regular care. As Dr. Tomlinson mentioned, all the things that are important, the policies, but also the services. And so I think we really have to understand that science is going to be really important, as it has been in treatment science for HIV. And it's very important right now, as we see today's paper, Atlanta Journal-Constitution, covering the latest you know, vaccine discoveries. But then we have to get public trust. And there's a huge amount of distrust among communities of color regarding their willingness to take the vaccine. And we can get into why, but here we are, December 1st, 2020, and we really, all of us activists, all of us in the health, you know, health activists have to really engage the communities, you know, where they are. And it's going to be really difficult because of all the lockdowns, and we're all on Zoom and we're isolated, but we really have to think hard about how we're going to do that. And that was how we really scored some successes in the HIV response globally and domestically, is that we let communities take the lead and not just have a sort of a top-down do what you're supposed to do sort of approach. And so we really, groups like Sister Love and the One Campaign and many hundreds and thousands of other community-based groups we need to give them an opportunity in the space to step up and to take that criticism seriously, because it was a broad coalition that came together for the HIV response. And if I can just gratuitously jump in here and give you a couple other items to think about. I think the AIDS movement took a victory lap too soon, too prematurely. Certainly, when I started working professionally in the AIDS movement, only 3 million people were on treatment. Yesterday, or a few days ago, UNAIDS announced, and Dr. Thompson, correct me on my numbers, about 26 million people are on treatment, which leaves about 12 million not on treatment. And that's an enormous milestone, but it's still, we're still way off track in terms of controlling the epidemic, reaching epidemic control. And Dr. Thompson can tell you what that, the scientific definition of that. But for me, it means eliminating HIV as a public health threat. It's no longer an epidemic. And we are nowhere near reaching that goal, either domestically or internationally. So I'll stop there with my, my speech here, but and let you jump in here.
I appreciate your perspective, but why aren't people in treatment? And what's been done to reach them?
My opinion is stigma. There's still a lot of stigma about just getting basic care, about getting basic prevention services. There's a lot of stigma about, where are the condoms in the bar? I remember when you had to buy the condoms, they were behind the counter. And now obviously today that's not the case anymore. But we still have a lot of stigma about sex, about drugs, about, multiple sexual partnerships. We have in the United States, Charles, I think you mentioned earlier, we still have HIV criminalization laws on the books, where you can get a lesser sentence for vehicular homicide in some states than you can for, inadvertently even exposing someone, not infecting someone for HIV. That's horrible. And so those laws are in place because of stigma. And I could go on, but I know in AIDS Healthcare Foundation, we proudly serve 1.4 million people in our care. Most of them are living with HIV, but we don't put AIDS on our clinic doors. We don't even spell out the name of AIDS Healthcare Foundation on our clinics here in the United States because of the stigma associated with going into a clinic. We find facilities that there are many other kinds of clinics like maternal health or radiology or something like that, so that someone isn't going to the AIDS clinic. They're going to a healthcare, a professional health medical building. So those are some of the things that we still, stigma is still killing a lot of people. And I think, our colleagues in this discussion from Atlanta may want to chime in here as well. But that's why I think we still have so many people not seeking treatment.
Yeah, I think that's a piece of that story that always boggles my mind. I've written many stories about HIV/AIDS, and people keep telling me stigma is still the gas that's fueling this epidemic. I don't understand.
Can I add one perspective just from an international lens? I think stigma is definitely one of the things preventing me from getting access, for sure. But I can never forget a day like today, a few years ago, we had a session in Nigeria, and the economic impediments are also real. I think, again, it was Charles that mentioned sort of institutional barriers to providing services, keeping that person at the center of service provision. There are young activists and people living with HIV/AIDS, and the lady talked about getting her medication, and she needed to get about 1,000 naira to go from her, and 1,000 naira today is probably $2. The Naira is dropping. So it's about $2 to get from her home to the hospital to get her drugs for free, because thanks to PEPFAR Global Fund and the Nigerian resources, a few people can get their antiretrovirals for free. But she didn't have the 1,000 Naira to go one way and the 1,000 Naira to go back. So her own economic situation actually kept her from getting access to these drugs. And a lot of the adolescents living with HIV and AIDS, because again, of our high unemployment rate on the continent, in Nigeria, unemployment rate among the ages of 25 to 35 is about 25%. So 1 in 4 are unemployed. Their resources to manage their health is lacking because then they're getting from their parents. So I think we can't overlook the economic realities that some of the people living with HIV and AIDS face to just reach those drugs, at least from where I sit.
Okay. I'm glad you spoke up because I wanted to direct my next question to you, Sarah. How has COVID-19 disrupted the HIV response?
Yeah, and I thank you for that, Gracie, and thanks for having me here. A few things have happened. One of the things that COVID made bare was the health inequities. And so those who are concentrated in the poor parts of the country, vulnerable populations like women and men who have sex with men, sex workers, those populations were disproportionately hit by the COVID pandemic. They already hit prior to, but it deepened. Access to healthcare, because of COVID, a lot of people didn't go to clinics to get what they needed. So access to healthcare was definitely impacted. Health workers, availability to treat anything other than, at least when COVID first came on, we were preparing as a nation, as a continent, for an onslaught to hit us, realizing that our healthcare system is already fragile and vulnerable as it is. How are we going to survive this thing? The attention clearly went, we saw immunizations of children go down. We're set back many years from COVID. People weren't going to get the kids immunized. Routine care that was required for contacting with the healthcare center was reduced significantly. And COVID was sort of top burner. So we saw that. We've also seen that what the lockdown did for the environment of a lockdown in the US and in Nigeria, completely different things. Most people in a country like Nigeria, 80% of the population are not working in the formal sector, so they're working in the informal sector. What that means often is that they need either a daily wage to live, or they need to sell something to get a wage to live on. With the lockdown that we had, the first lockdown we had was a full month. People's daily wages had reduced completely. Nigeria already has a high amount of poverty. It's actually, unfortunately, referred to as the poverty capital of the world. We overtook India by having the most amount of people living in poverty. What COVID did was plummet that number even further. So more people living in poverty. So less people have more to work with. And we're seeing that show up with the 12.6 million people living with HIVs who are still not receiving treatment. And we are assuming that that number will even go higher because of the current economic context. While we didn't get the onslaught of COVID as the West did, what we got was a destabilizing economic situation that is impacting everybody on the continent. And because our economies can't withstand what is happening, we're increasing debt, it's plummeting us even further as nations. And the other thing I'll add before I hand off back to you is when we're here a few decades ago, where there was a pandemic of sort of disproportionate proportions, we realized that it takes about 7 years between when a medicine is created in the US or Europe and it gets to the hands of people on the continent. So the people, 7 years, that journey is 7 years. So, and I think it was John that mentioned, we left the treatment to the hands of the pharmaceutical companies. This time with COVID competing with other ailments, competing with treatment for HIV AIDS, we're asking that question, are we gonna let history repeat itself? Because the longer the vaccine takes to get to us, the further down everything else goes down the radar, the more attention the government is putting on COVID-19, and it's cannibalizing all the other diseases. So we're trying to make sure it's top of mind. Let's address that, but let's also address other things that are happening. So we're unfortunately, we are seeing a regression. We will see a regression that it will take years for it to show up. And the advances we made for the last few years have been eroded by COVID, no doubt about that.
Wow. Dr. Tomlinson, can you talk a little bit about how these twin pandemics have impacted underserved populations?
Sure. Thanks, Gracie. And I'll be brief this time. I think I talked too much last time. I will say that, so when we, in global settings, talk about our work with key and vulnerable populations or members of key populations, we typically mean men who have sex with men, female sex workers, persons who inject drugs, prisoners, and sometimes a couple of other groups. But many of those folks, as I think John said, and as is reflected in our conversation about the domestic context, those folks live an everyday experience that is not infrequently stigmatized. And so that we have worked very hard to try and address stigma. And it's hard because there's very little that you can do at an individual level, which is often where you have access to someone in a health service delivery system to address things that are sort of rooted in, sort of ecological, structural, and institutional factors. You can work at the individual level, but it's hard to make attitudinal changes for folks beyond the person with whom you may have contact. And so we've worked really hard to try and address stigma and discrimination at the levels where we can. And what we've seen is that there's some backsliding with regard to stigma and discrimination for people living with HIV. And there are different kinds of stigma among people living with HIV. So, an adolescent girl living with HIV in sub-Saharan Africa has a pretty different experience, but still an often stigmatized one compared to a man who has sex with men, or a commercial sex worker who, is engaging in sex work to put food on the table and take care of her children. All of those kinds of stigmas seem to have worsened again during the time of COVID-19. And so it's something that we're aware of, we're mindful of, and that we desperately want to address. And we're doing it in the ways that we can. But right now, to be quite honest, our approaches are inadequate and not wholly sufficient. I think that this is an area where the global community is trying to come together, and this may be catalytic as we think about post-COVID recovery for programs and services directed towards PLHIV, to try and marshal the global resources and the global sort of brain trust to try and double down on these issues and solve problems that we haven't been able to solve in the past.
Okay. So Sarah, you might have mentioned this before, but I was curious about how COVID-19 might have impacted the PEPFAR funding and, other related organizations' responses to the HIV/AIDS epidemic.
I'll pick it up where Hank left off. I think the global responses are really important. One of the things we saw with HIV and AIDS is that multilateralism, when countries get together and decide they're going to, move forward or create a policy, to Hank's example, it really makes a difference. And one of the things that we see is that PEPFAR was that. It was led by the US, and we're really grateful for that. That global partnership, put our hands together, let's make this thing happen, is really important. And I feel like we were losing that. We have been losing that. And we just need to double down on that global response. It matters. One of the things we're seeing PEPFAR do is increase its flexibility in funding, which is really important. We talked about the community being at the center because the community does know best about how best to address issues. And sometimes the double-edged sword with donor funding like PEPFAR or Global Fund is it can be a bit top-down. So here's what I would like you to do with the money. And if you're not going to do this with the money, then you can find money somewhere else. We're seeing some shifts with that, which is really important. Environment like this that was not planned, COVID, we do have to, we appreciate the flexibility that PEPFAR has provided to allow communities to move as they need to move. So that I have to applaud it. It's very important. I also think that we have seen some adapting. So PEPFAR also provides technical support to communities. So to increase maybe communication or the stigma issue, how best should communities get engaged with their communities around these issues. So that technical ability has been really important. Global Fund is also really important to this. I know that's some of the work that we're doing at One and with our sort of for-profit arm Red. It's getting a lot of organizations not to miss our mark on our funding for HIV, AIDS, TB, malaria, especially now when, again, there's this disease that has come in and is taking everyone's attention and resources. I think the nightmare situation is that resources get shifted from Global Fund towards COVID because the needs are still very present. So the flexibility is super important. PEPFAR is also supporting a lot of diverse needs. So a country like Nigeria is not a monolithic country. The Northern Nigeria reality is very different from Southern Nigeria reality. Within Southern Nigeria, there are many different realities. Between communities and communities, very different realities. So how do we ensure that PEPFAR actually adapts, the solutions to these communities? And I think we're seeing that adaptability, that flexibility. We can see more of it, but we're seeing that happen, and that's greatly appreciated.
Thank you for that. John, what role do you see activism playing in these epidemics?
Well, without activism, the public health systems doesn't get motivated. And I'm not a public health professional. I'm only licensed to drive my car, as I tell people. So, but we have to have the communities, and we have to have sharp-tongued activists to really hold governments and big institutions accountable, universities, big newspapers like the Atlanta Journal-Constitution. We have to have people like the Press Club advocating for a correct response to these multiple epidemics that are all over the place, here at Atlanta, nationally, domestically, and then internationally as well. So I think activists, frankly, if I can be very honest with you, have kind of been a little complacent. We go to work for AIDS organizations that are grant funded. We don't want to get the people who decide what grants you get mad at you, and so there's this sort of Stockholm syndrome that develops where, okay, we don't want to offend the jailer, and I'm making this sound a little I'm overstating the point, just to express to you that I think activists, the ACT UP days are long gone. Nobody's throwing blood at the headquarters of the FDA. No one's throwing the ashes of their lovers, that's what we used to call them, over the gates at the White House, because you can't, well, there's lots of reasons for that now, but you get my point. We don't have that sort of fire anymore. And, when we talk about PEPFAR funding, we have flat funded the international AIDS response since George W. Bush left office. We've had the same number in the budget every year for PEPFAR and for the Ryan White program, which is the domestic equivalent of PEPFAR. That's outrageous. We should be up in arms about that. We've had all kinds of appropriations bills in the trillions of dollars, right, for COVID-19. Nothing extra for the COVID response. And those of us who've worked in clinics now under COVID, you have to, as Dr. Tomlinson said, you have to decongest your clinics. So before, where you would see 13 patients a day at a US clinic, I realize it's quite different than Nigeria. Now you're only seeing 4 or 5 because you're spacing them apart. So you still have to keep the lights on, you still have to pay the staff. So there's a requirement for extra money for both PEPFAR, the Global Fund, and the Ryan White program. But I don't see the demonstrators for that right now, Gracie, and it's really kind of disappointing. But perhaps, this is more than a huge wake-up call with what we're dealing with now with COVID right now.
Yeah. And that's a great transition point for us, John. And Gracie, thank you for those questions and all the panelists. I think we're going to take a few audience questions just in the last few minutes here as we wrap up. A question here is, do people who have COVID get better treatment from politicians than people who have HIV? I think John just alluded to that a second ago, but I mean, I think that speaks kind of to the situation of, immediately how, and we should be trying to, as a country or any country, trying to respond to a public health need immediately, obviously. But does anybody have an opinion on that? Do COVID patients get better treatment from politicians than those with HIV?
Well, I'll jump in here, and I would say I don't think so. I think politicians are responding to this emergency, and there's a it's very life-threatening what's happening with COVID. So it's threatening our economy and threatening our overall health system. Our hospitals are overwhelmed. Our whole healthcare infrastructure is overwhelmed. But I would expect that there's not the same kind of stigma associated with COVID as there is around HIV. But having said that, I know that Asian Americans have been targeted with hate crimes. So it's sort of a mixed bag, in my view.
I think what I'll say to that is there's more resources, if that is a proxy for better treatment. One of the manifestations of COVID on the continent was the first big casualties were politicians. And because our healthcare system is so fragile, typically a politician will leave to the US or London for treatment. It was the first time the borders were closed, so they had to live within whatever system was existing in the country. It was also the first time where it was so contagious and they were getting it. So all of a sudden, the national resources were poured towards COVID because likelihood of them getting it is really high. And so there's kind of some self-protection involved. So we did see quite a bit of resources. We found the resources to address COVID. So if that's a proxy for better treatment, perhaps, but I don't know that person to person, the treatment is better. We do have some stigma with COVID here. People will say, oh, I have a cold, and they'll reel out their symptoms and it's all COVID related, but they wouldn't use the word COVID because there's a little bit of a stigma affiliated with that here in Nigeria.
And I think we have two more quick questions. Sheena, did you want to chime in with an audience question?
Yeah, we have a question from Amara Kennedy. I hope I'm pronouncing that correctly. She asks, or they ask, how can journalists best cover the ongoing HIV epidemic, particularly the various domestic issues that have been shared?
I would say start by talking with people living with HIV and learn their story. Oftentimes it will be very different than the common narrative that we have of folks who are living with HIV. And I think representing folks' reality authentically expands the conversation and advances exactly what the goals are and should be. And then secondly, I mean, there are institutional failures galore. If you want to talk about HIV, you can just look at any HIV program, whether it be Atlanta's housing opportunities for people with AIDS, or Fulton County's Ryan White funds. There are so many institutional shortcomings in the way that this crisis is being held, and it's just fallen to the back burner, and it's just become another bureaucratic, channel that, if you want to find, stories, they're always there.
I would say three things. I'm sorry.
I was done.
I would say three things come to mind for me. The first thing is, I hope that there's a greater investment in community journalism. which may look like working with folks, maybe not traditionally trained in journalism, but very much impacted by or living with HIV to tell their own stories. I think that could be incredibly powerful. Connected to that point, I would love to see maybe innovative partnerships between either individual journalists and community organizations, or perhaps a major publication, say the Atlanta Journal-Constitution, and a community-based organization where they can actually work together to maybe do a series where people are, activists are featured. I mean, I think next year, 2021, creates an interesting opportunity where there'll be a lot of reflection about what does it mean to be 40 years grappling with HIV. And I think and hopefully with there being sort of this moment to reflect, there'll also be a commitment to innovative ways to tell stories. And finally, I would add, I think Atlanta has so many really, really interesting stories. Certainly one of, significant failures, but also I think some really interesting successes. I think because of our civil rights history, because there's always been an intersection, I think, between civil rights movement leaders who have been very much on the front lines of HIV advocacy. We have figures like John Lewis, who was very much concerned with HIV. And I think as we honor his legacy, part of that legacy is him being on the vanguard of HIV activism. We have figures like Coretta Scott King and others who have been, champions. I think, unfortunately, there's been a narrative that Black people, particularly Black communities, have just been sort of really, we've had our head in the sands. We think about histories of HIV activism as only being about white activists, but we don't know that there've always been Black people from the beginning, Black leaders, even civil rights leaders, who've been on the vanguard of HIV activism. And so I think that story could be a really critical and really important story to tell. So hopefully we'll see that happen.
Okay, great. Thank you for that, Charles. Okay, final question to all the panelists, and we'll wrap up from there. The vaccines that are forthcoming for the coronavirus, COVID-19, it's amazing the time that they were produced in. I mean, it really is an accomplishment and wonderful that will be rolling out from what we hear. But I'm wondering for you, I know that the United Nations and a lot of programs around the world have always had these numerical goals. So, 2030, I know, has been a big goal for achieving a lot of things in terms of the Sustainable Development Goals and other things. But when do you think that we will be able to say that we have conquered HIV/AIDS? I mean, that we are seeing those very low numbers that make us know that it's no longer an epidemic. Will it be 2030? Will it be sooner? Has COVID motivated us in ways that we can now say, hey, look, COVID's been around a year. HIV's been around much longer. Obviously, two very different things, but in terms of the way we treat viruses and how we learn to get a handle on them and eradicate diseases. What do you all think? Just any optimism here?
Let CDC go first.
So I'll speak just on my own sense of things, and so this is not necessarily the agency's sense of things, but I will just acknowledge that there are tremendous market forces that were brought to bear for the global accelerated effort to find viable vaccines, or to create viable vaccines for COVID-19 that don't exist for the global HIV epidemic. And so when you think about what folks in the global north are willing to pay for a COVID-19 vaccine, you've seen early investment before vaccine efficacy has been demonstrated to the tunes of billions and billions and billions of dollars in major pharmaceutical companies, because the vast majority of global HIV burden isn't located in high income global northern countries that cannot pay those things. I don't know that we will see we won't see the market forces come together for HIV in the same way that they did for COVID-19. But what is incredibly exciting are just the two things. Like, this does show what is possible when the global sort of scientific and academic and pharmaceutical sort of efforts align, and how quickly something can be done and progress can be made. But the second really encouraging thing is, independent of this vaccine effort for COVID-19, we have the resources and the tools necessary to control global and local HIV epidemics right now. And I think that we've had so much informed conversation here, which properly locates responsibility in systems and structures and not in individual people and their risk behaviors. And it's in dealing with those things, should we choose to, and should we turn our attention to, that will allow us to utilize those tools that are already in the toolbox that can get us there.
Perfect. Well, I
I can
will.
chime in.
Oh yeah, quickly. Yeah.
Sure. With the when, I think the when is when we decide there's sustained intent, because it's true that we can. There's a saying we have at one, which is none of us are equal until all of us are equal. We turn that around, say none of us are safe until all of us are safe. Until we truly realize that as a nation. Right now, we're fighting for the vaccines to be devoid of IP, intellectual property, because so that manufacturing can happen and it can be well distributed. Of course, pharmaceutical companies don't like that idea. But again, none of us are safe until all of us are safe. And I hope that translates to the HIV and AIDS pandemic as well.
Thank you for that, Sarah. And thanks to everybody for this wonderful event today, for your participation. Thank you to Gracie Bond-Staples from the AJC for being our moderator and for her work, of course. Panelist Charles Stevens from the Counter Narrative Project. Panelist Antoinette Jones from Sister Love. Panelist Ryan Lee from the Georgia Voice. Panelist Dr. Hank Tomlinson from the CDC. Panelist Sarah Maka-Ubabe from the One Campaign, and panelist John Hassel from the AIDS Healthcare Foundation. Thank you all. It was a undertaking getting everybody on, but I really enjoyed all the different voices, and everybody had great things to say. So onward we go, and stay safe, everybody.
Thank you.
Thank you.
Thank you to the Atlanta Press Club.
Yes, and please join us at atlantapressclub.org if you want more information about what we do as the club. And don't forget to watch our debate series this Sunday on GPB. Take care.
Thank you.